Good afternoon, everyone, and welcome to the Poison Hour session for this month. Thank you for joining us today. My name is Dr. Samia Ghanay. I'm clinical toxicologist and senior specialist in poison information at the Department of Health, and I'm the vice president of the ESEM Toxicology Committee. I will be your moderator for today's session. Before we dive into the core presentation, I have just a few quick housekeeping notes. First, all attendee microphones will remain muted during the presentation to ensure the highest audio clarity or quality. However, we highly encourage your participation. Please use the Q&A box located in the bottom right of your screen to submit your questions at any point during the webinar. And we have dedicated time following the presentation for live discussion. So we will monitor this closely. This session will be recorded. I started the recording already, and you will see also the recording later. So today we are focusing on a critical and continuously evolving area of our practice, the management of pediatric poisoning. So as healthcare providers, we know that children are disproportionately vulnerable to accidental exposures, whether it's navigating the risks of household cleaning products, pharmaceuticals, environment hazards. So always the pediatric toxicovigilance requires rapid assessment and specialized clinical knowledge and a strong public health perspective. We are fortunate today to be joined by an expert who brings a wealth of clinical expertise from the front lines of emergency care and medical toxicology to help us navigate these exact challenges. It's my pleasure today to introduce today's speaker, Dr. Lara Suleiman, an emergency medicine consultant and lead of the toxicology consultation service at Rashid Hospital Trauma Center, Dubai Health. Dr. Lara holds a distinguished board certification across the Arab, European, and UK Royal College of Emergency Medicine, alongside of postgraduate diploma in medical toxicology from Cardiff University, and a diploma in health leadership as well and innovation from RIT Dubai. In addition to her high acuity clinical work, she is also a dedicated medical educator. She serves as core faculty at MBRU, and where she leads the toxicology rotation for emergency medicine residents, and she's also adjunct faculty at Dubai Medical University. Her combined expertise in frontline emergency medicine and specialized toxicological management makes her the ideal expert to lead today's discussion. Dr. Lara, thank you for being here. I will hand it over to you.
Thank you, Dr. Samia, for your introduction, and thank you everyone for having the time to join us today. I hope my voice is clear.
Yes, perfect.
Okay. So when we talk about pediatric exposures, usually I know that most of us, especially the ones who are not working in a dedicated pediatric emergency, when they will see kids or pediatric patients, they will be a little bit uncomfortable. However, if you have them with overdose or drug exposures or toxin exposures, you will feel that it's more complicated. So today we'll try to touch on some basic things and some tips and tricks when managing pediatric poisoning. Sorry. Okay. So I have no conflict of interest in my presentation. So just about having an idea about pediatric toxicology, that I decided we love to practice things and to try things firsthand. So me as a child experienced iron overdose as a kid. I took my mom's multivitamins, so I think this was a sign that I might have this presentation years later. So today we will just have touches about the use of risk assessment tools and risk assessment mindset mindset when we are managing those patients. Try to recognize the importance of resuscitation and management in those patients, especially under the presentation of poisoning, and to decide on planning how we will manage the patients before ahead of their arrival, and to decide the role of GI decontamination and the management on those patients. So for pediatric poisoning, usually they are not like adults. Most of the time it's accidental ingestions or unintentional ingestions. And the best term we are using currently is exploratory ingestions, because most of the kids, especially the ones who are below the age of teenagers, usually they will ingest these medications or these exposures out of exploration. They will find a fancy pill or they will find a fancy bottle that they want to explore what's inside it. So if we're looking about the statistics, we have in the American poison centers, they said that around more than 50,000 of ED visits are related to per year, are related to children below 5 years old who had a type of poisonous exposure. 56% all of the out of all poison presentations and exposures are related to pediatric population, and around less than 1% of them, they will have toxic fatalities are related to children below 6 years. When they looked into the common ingestions, the most common one is cosmetics and personal care, around 10%, and also 10% for household cleaners, which shows us how accessible these products can be. That's why they are the most common ones, followed by 8% of analgesic and 7% of dietary supplement. And then you have around 6% of toys, foreign bodies, button batteries. I believe that you cannot have a pediatric ED shift without having foreign body ingestions in kids. Okay. And regarding the cleaning products, I think everyone knows a few years ago we had this Tide Pods challenge where they start to try to swallow they challenge each other in swallowing the Tide Pods. And everyone knows they started to realize that they are highly caustic, and the ED started to notice a lot of caustic ingestion between teens during that period. They were doing these TikTok challenges. Okay. So we'll have 3 cases, and just we'll have the history, and you can think about the case, and then later on we will discuss these cases. So you have an 18-month-old girl who was unresponsive, and the grandmother came to her brought her to the ED because she was unable to wake her up from her nap. The child was not ill in the morning. She was found holding her grandmother's pills box early in the day before her being found unresponsive. Uh, the grandmother said that she is not using the pills inside this pill box, so she does not recall whatever medications are inside. And the patient was brought by the ambulance. So when the patient was examined, there is shallow breathing and responding to pain. She moans and withdraws and does not open her eyes. There is no fever, no signs of trauma, and there was no other abnormality in the examination. So we need to think about what are the medications that can be fatal in such small doses if it's only the pill box of the grandmother. And in these cases, we need to consider opioid sedative, could be a cardiac med, a hypoglycemic agent. At that time, the patient needed immediate stat ECG, glucose levels, and they were established with IV access. And we need to know that can we use activated charcoal or no at this time. The grandmother does not recall the last time she saw the kid. And usually in those cases, you need to take the history of the grandmother of her medications. She's diabetic and hypertensive. So always keep the sulfonylureas and cardiac medications in your mind. The second case will be a 15 years old possible suicide attempt. She ingested acetaminophen and hydrocodone tablets. So she sent a text to her friend that she took a whole bottle of pain pills. Family found the empty bottle of acetaminophen with hydrocodone in the bathroom cabinet. She is not sure how much she took out of the pill. how much there were pills remaining in the box. And it was like around 4 hours. And this was confirmed by the time of the message that was sent to her friend. And this is one of the things that we need, it's challenging for us in ED. And we need to try to find the best or the nearest time, the closest time of ingestion by asking the people around the patient, like, when was the last time you saw them? What was the last time they had the food? Or when was the last time you spoke to them? Last time seemed normal, to approximate the time of ingestion. The patient is tearful, tired, answers questions appropriately, normal vital signs, normal examination, altered mental status is normal. So you need to ask at this time, which drug levels should we check them? Should we give naloxone or no? Because she said you took hydrocodone. Uh, should we give activated charcoal or no? The time was around 4 hours. Shall we start immediately NAC or not for those patients, or when it's safe to transfer this to psychiatry? These questions, we'll address them later on. Then you have a 9-month-old baby. The mother brought to the ED because she applied wintergreen ointment on the chest for cough. The mother applied it for cough relief, and then she noticed the safety warning on the box about children toxicity. So she came directly to the ED. She's worried. There is no ingestions orally. And the child is normal, breathing normally, physical exam normal, vitally normally, completely asymptomatic. And in these questions, we have to ask these questions like, what's the amount of exposure of such exposures that can be considered as toxic? Will topical application consider toxic in such cases? And how can we work up those patients, and how long we need to observe them? So we need always to remember that oil of wintergreen contain methyl salicylate, and it's a very highly concentrated form of salicylate. And in pediatric especially, a toxic dose of 0.2 milli per kg is quite toxic. Okay, so we're back to our little explorers. So the key point in these, that most treatments in pediatric is supportive, not like usually in adults. You will not have a lot of interventions compared to the adult management. And you need to remember always to suspect abuse. In pediatrics, we have to remember that there is child abuse sometimes. If you have a child who is below 1 year or between 5 to 11 years old, if you have a multiple agents that they do not make sense involved, if the drugs are illicit drugs, like if you have a child with a exposure to heroin or cocaine, we need to consider child abuse on those things if this is in the household. If you have siblings who have similar presentations or multiple presentations to the ED with such symptoms, and if you have a massive ingestion in a young child. Kids, usually they don't come with massive ingestions. So we need to keep an eye at child abuse or a domestic violence in such scenarios. Pediatric usually are exposed to more than household and personal care products than adults, and to more of psychopharmacological agents compared to adults. Okay. So regarding when we speak about pediatric overdoses, and we noticed that there are some procedures that they were done previously to reduce the dangers of exposure to those drugs, to pediatrics. So the iron they noticed, and this is one of the things that preventive medicine or prevention is better than cure. Previously, iron tablets were kept in such tapes that they are easy to be opened by kids. So they had high presentations of iron ingestions in pediatric populations. And you see how colorful they are. They are tempting for them to be tried. But then when they change the types of bottles to these bottles that are difficult to open, and this was maybe around in the 50s or 60s, they noticed a dramatic drop in pediatric exposures to iron. And this started to be applied on other medications. If you notice, the sealed medications, the sealed bottles, or the difficult to open bottles. And also they start to reduce the amount of pills per box or amount of pills dispensed per box. So you will not have access to large amount of tablets during in the household. Our children just small. I remember when we used to do our pediatric rotations, they used to tell us like pediatrics are just small adults. And this is the most wrongful statement ever to learn. Pediatrics are not, our children are not just small adults. They have pathophysiological differences compared to adults and metabolic differences compared to adults. So what are physiological differences in children that will affect our assessment for them, not only in poisoned exposures, but also in general? So their absorption is different than adults. They have a larger body surface area, so skin absorption will be higher in those kids. They have increased skin moisture and hydration, which will make absorption from the skin faster compared to adults. They will have increased skin perfusion, so blood supply to the skin is more to kids, and the more blood supply you have, the more exposure you will have. They have increased respiratory rate, so their reserve is not as adults, and they will be tachypnic and have respiratory distress faster than adults, and they will have increased minute ventilation. So those kids can their respiratory drive can be affected easily rather than adults when they are exposed to any drugs that they will cause respiratory depression. The higher metabolic rate and decreased reserve make children more sensitive to hypoxia and respiratory failure. Increased reliance on the diaphragm and limited capacity of other accessory muscles lead to the abdominal breathing characteristic in kids, and this will increase the tendency of fatigue and respiratory failure. The situation that can affect the child's reliance to a direct respiratory toxin, such as aspiration of hydrocarbons, as well as the ability to compensate for acid-base disturbances. So all these factors will affect their response to acid-base disturbances. They will affect their respiratory reliance and resistance to drop and go into hypoxia in such exposures. The relative lack of glycogen storage, they will make them more prone for hypoglycemia from alcohol or ethanol exposure and beta receptor agents due to low glycogen storage. That's why hypoglycemia in pediatric after ingesting alcohol or in beta blocker exposure are more common than adults. The cardiovascular functions in pediatrics, they depend more on heart rate. So they will have limited ability to increase their stroke volume, and they will have increased adrenergic tone, which will mean that those children, they will have a limited cardiovascular reserve in response to stress. They will have delayed cardiovascular collapse than adults. So these kids, they will collapse suddenly. You will not have the marks and the signs of symptoms of circulatory shock before going into the shock like adults. So adults, they might become lethargic, they will become tachycardic, they will have signs of hypoxia. But kids usually, they can suddenly collapse because they don't have the reserve and compensation like adults. A child impending circulatory failure may appear stable with a normal blood pressure and tachycardia as the only abnormal vital signs, and then suddenly they will collapse. Drugs that induce bradycardia, like calcium channel blockers or organophosphate, may precipitate circulatory arrest in very small doses because of their poor cardiovascular reserve. And children can be more acidemic at initial presentations with salicylate poisoning compared to adults, and may have more severe acidemia with other clinical scenarios such as toxic alcohol and poisoning. Seriously poisoned children may pass rapidly from minimally impaired respiration to deep coma and apnea. And also, children with seemingly normal respiratory drive may suffer of airway obstruction as a result of their narrow airway caliber, copious secretions, and depressed airway protection reflexes. So we need to make sure that those kids who have increased secretions, we need to address and protect their airways earlier than adults. One other thing for pediatrics, that they have a poor maturation of CNS receptors in children, especially young children. We are not talking about the children who have a well-developed CNS. So the long observed phenomena of agents that cause specific toxicity in only in young children. So patients with CNS depressant medications, they might need a longer duration of observation rather than adults because they still have a CNS, poor matured CNS. So they will present later. The CNS depression can come later. Many opioid receptors agonists and their structural isomers can enhance CNS and respiratory depression in children, including dextromethorphan cough syrups, clonidine, antimalarial, codeine, and buprenorphine. And young infants are more prone to paradoxical reaction to benzodiazepines and increased tendency to have a QTC prolongation with sotalol and other antiarrhythmic compared to adults. So you can see that children are not small adults. They have a huge physiological differences that can alter the metabolism and presentation to those patients. And we need to be sometimes more cautious or more aggressive with those patients. There is a term that we always know about it, one pill can kill in pediatrics. Maybe it's not an actual one pill, okay, but pediatric patients can go into fatalities with very small doses of drugs that can be normal in adults. And there is a huge list of these medications like antiarrhythmics, antimalarials, antipsychotics, beta blockers, calcium channel blockers, camphor especially, they come with refractory seizures. Clonidine, who they can present with opioid-like presentation, methyl salicylate, sulfonylureas, TCAs. They say sometimes theoretically that one tablet of calcium channel blocker can be fatal to pediatrics. The same goes with beta blockers. The opioids, especially now, there is these sublingual patches that they are using, the buprenorphine patches that go sublingual. They can be fatal with one patch only. Iron tablets, if they go more than 20 milligram per kg of elemental iron, they can be highly toxic to kids. Lomotil, which is an antidiarrheal medications, usually in pediatric especially, they can have delayed CNS manifestations and delayed presentations. So sometimes they need more than 6 hours observation, even if they are asymptomatic initially. Okay, so how we will approach a poisoned child? So usually we always say that we go with ABCs, but in pediatrics and in poisoned patients in general, we need to add two important categories: your risk assessment and your decontamination when you approach these patients. And sometimes your decontamination can outweigh or go before your ABCs even in some situations. So you'll do your risk assessment, you will assess your decontamination, you will go with your A, B, C, D, 3, E, and F, and we will go through them in a moment. Then we will have the decision of enhanced elimination and the decision of specific therapies. So your risk assessment, what do we mean when we say risk assessment? So risk assessment is just a distinct cognitive process through which the treating clinician will predict the likely clinical evolution and potential complications for that individual patient at a specific presentation. So when we have the child who present to us or a patient who will present to us, we need to have in the back of the mind, what is the risk of this patient? Will this patient deteriorate? So this patient will require an ICU care. Do I need dialysis or do I need to communicate for hemodialysis? Do I need a specific antidote that it might not be available in my hospital? I have to bring it from somewhere else. Or do I need to transfer this child to another specialized center? Do I need to be prepared for multiple presentations or multiple exposures of the household? Like, for example, if a child came with an organophosphate exposure or a pesticide exposure, do I need to prepare for other siblings or other house members? And this will allow us to have informed decision regarding subsequent management, and we'll have adequate resource utilization and a timely appropriate disposition. Then for our airway assessment, it's the same as assessing any patient. You have to, in the ED, you need to assess for the airway. In poisoned exposures, usually, sometimes we need to anticipate an early intubation or an elective intubations for patients, even if they have maintaining their respiratory drive, even if they are maintaining their airway, because we might expect that this patient will deteriorate. And we don't want to have a delayed intervention after they deteriorate. You don't want to intubate someone after they develop the hypoxia or after they go into cardiac arrest, or if the patient you are expecting them that they will go into multiple seizures, that they will require high doses of benzos, or you will be unable to control their seizures, and eventually you will reach to intubate them. You might need to intubate them earlier before any complications. You will assess their breathing, their circulation, the risk of seizure, and it's very important to address hypoglycemia. If you have an altered mental status patient, you need to always check their glucose, because sometimes it's just as simple as a reversible hypoglycemia. Or if you have a child of unknown ingestion and come to you with altered mental status and you find this child is hypoglycemic, you can narrow your differentials of drugs. You will keep beta blockers, alcohols, or hypoglycemic agents in your mind. And then you need to address and treat the hypo and the hyperthermia, because you know that in hypothermia medications will not work, and hyperthermia also the same. It's really difficult to handle those patients. It might be the result, the hyperthermia, the reason of their agitation, or the hyperthermia is a result of continuous seizures or muscle contractions. And then you will look into your resuscitative antidotes. Do I need to give an antidote now, or I have to have the antidote available in 2-3 hours for those patients? So airway, breathing, circulation, and then you go with your 3Ds. So your disability, the drugs. So you need to know what did the child take, or you need to at least have an idea or a possibility of a drug exposures, and decontamination. Then you will have your ECG and the fever, because as we said, many patients, they will have hyperthermia as a result or as a part of the toxidrome that they are presenting in. ECG is very helpful, especially in unknown ingestion. So if you have a child who have a low GCS, and then you can find the patient is bradycardic or heart block, you will think about beta blockers, you will think about calcium channel blockers. If you see in the ECG QT prolongation, you will think about sotalol specifically. If you have a wide complex QRS, you will think about like beta blockers like propranolol, or that has a sodium channel blocker properties. You might think of TCA. So ECG is important in those situations. In pediatrics, we always think of the worst case scenario. So if you have the time of ingestion, you will consider the latest possible. So if the mother said that my kid had breakfast at 7, and then at 10 he was playing with his siblings, and this was the last time I saw him normal. So we'll consider like the time of ingestion was at 10 a.m., for example. We will count all missing pills. We will consider them has been ingested. So if they will bring you a bottle of empty bottle of 50 pills, you will consider the 50 pills has been ingested by the child. And if the mother will tell you, I found a bottle with medication syrup has been spilled on the floor, and for example, let's say that it's 150 ml of the syrup bottle, we will consider that the child ingested all whatever in this bottle, and we will not say that half of it has been spilled on the floor. If you have more than one child is involved, each child has consumed the all missing tablets. This is when you don't have a history, okay? You are not sure. The mother will bring both children, both symptomatic. She is not sure which one took what. You will assume that each child has taken the full amount that is suspected. If a sibling is available, so if there were multiple kids who are in the same room, you need to make sure that the other kids did not take the medicine also. You need to consider what type of agent, what are the doses, the time since ingestion, the current clinical status, and the patient's factors. Okay. Usually we measure the dose load by milligram per kg, and even I prefer this approach even in adults, because an underweight adult does not have the same dose load as an overweight adult. Usually in kids, it's difficult to ingest more than 2 to 3 tablets at a time, especially if it's something that it's exploratory and unintentional. Um, maybe in adolescents who have intentional might have more. The exact time of ingestion is mostly unknown, and this is one of the most challenging parts that we deal with. And we can try like to have a time interval, like when was the last time you have a call with them? When was the last time you checked on them? Like the kid would send a text message to their friends, so we'll assume that it happened after that time or approximately around that time. Okay, so when they arrive to you in the emergency, we will go with a thorough, detailed history and physical examination. You will secure their airways. You will consider early intubation in some cases. You will do the ECG. You will give fluids as needed. And if the patient had a chemical spill or on their clothes, you need to remove the clothes if contaminated. Then we will decide about the gastric decontamination and enhanced elimination. I remember when we used to do our pediatric rotations in pediatric hospital, each kid with any poisonous exposure, they will go through gastric lavage. And you will hear the kids screaming and crying. It's a difficult experience for them and for the mother and for the nurses and the doctors. And all of them, they will go for lavage. And then we change the management. But until now, we have the parents bringing their kids, asking us to wash their stomach, or they will come to you to tell you that they tried to induce vomiting, or they are giving them something to vomit. So we will see about gastric decontamination and enhanced elimination. So gastric decontamination can vary. It can be by activated charcoal. It can be by gastric lavage. However, gastric lavage is really out of the practice. It can be by physical removal with the endoscopy. It can be with whole bowel irrigation. And you can go with your enhanced elimination like multi-dose activated charcoal, urine alkalization, or ECRT like hemodialysis or extracorporeal methods. So what we have evidence related to activated charcoal in children. Most children are managed safely without GI decontamination. Single dose activated charcoal are considered only in lethal doses or if they present between 30 to 60 minutes and you have an intact airway. In some situations, we might give it beyond the 1 hour if we have an evidence of delayed absorption in these patients who took drugs that are anticholinergic that can cause ileus or delayed gastric emptying, we might consider giving activated charcoal beyond the 1 hour if the patient is awake and able to take it by their own and they have an intact airway. Children are most of the time are uncooperative, and there is a high risk of aspiration rather than adults. So to decide to give an activated charcoal in a child, you need really to have a clear indication or a clear benefit to give such a medicine because it tastes bad, it smells bad, and we try to mix it with them with juice or Coke or something to help them accept this medicine. You will never use it in caustic ingestions or hydrocarbons because of the risk of aspiration or chemical pneumonitis. And in caustic ingestion, if the GI tract is already perforated or damaged, you will make it worse. And if this patient will go for endoscopy, the gastroenterologist will love you if he will if they will see charcoal covering their GI tract. The dose is usually 0.5 to 1 gram per kg, maximum of 50. You can mix it with chocolate milk juice to improve compliance. Multi-dose activated charcoal is useful in certain ingestions like carbamazepine, phenobarbital, salicylate, and thiophyllin, which is we call it intestinal dialysis, especially for patients for drugs that have enterohepatic circulations. So the multi-dose activated charcoal is a repeated activated charcoal. It has a pharmacokinetics benefit, theoretically. but the clinical outcomes data is weak, especially in pediatrics, and you need to monitor for bowel obstruction and aspiration. We still use it, of course, especially in these drugs like carbamazepine, phenobarb, theophylline, salicylate. We still use it because theoretically, pharmacokinetic-wise, they will help to stop the anterior hepatic circulation, but we don't have enough clinical evidence about the outcome for those then. If you have a tablet in X-ray, lead paint chips or extended release medications like in calcium channel blocker or beta blocker, you will consider whole bowel irrigation with polyethylene glycol at 250 to 500 milli per hour, and your endpoint will be that the rectal outflux should be as clear as the fluid that you will give it to the patient, and most of the time it's through the nasogastric tube. Okay. If you want to speak about gastric lavage, because this is the thing that the family will request, and many of them, they will not be happy that you are not washing their stomach, and they might take the child to another hospital that would wash the stomach of their kid. You can notice that this is the quetiapine extended release tablets, okay, 4 hours after ingestion. And this is the 30 French orogastric tube, which is almost the largest size as possible. NG tube is pointless. You need a large orogastric tube, and you can see that still the tablets are larger than the tube, so this will have no benefit to do gastric lavage for those patients. They might benefit with whole bowel irrigation rather than a gastric lavage. So when we talk about a specific thing considered when poisoned child with cardiac arrest, you know that even now with the ACLS, they updated in their latest update, they considered even using resuscitative antidotes while you are running the code for patients with suspected poisoning. So early consideration for specific therapies and antidotes such as naloxone, sodium bicarb, digifab, insulin glucose, and calcium channel blocker should be considered even during the cardiac arrest. A child with a deep coma due to opioids can receive higher doses of naloxone without being worried of withdrawal as an adult, because usually most of the kids are not opioid dependent. And pediatric benzodiazepine toxicity is one of the indications to use flumazenil, especially if the child is not known to use benzos for epilepsy or for any reason. Okay, now for if we want to talk about enhanced elimination, which is the multi-dose activated charcoal, the urine alkalization, and the dialysis. Urine alkalization is the mainstay of therapy to moderate and severe salicylate toxicity. The multi-dose activated charcoal has been shown to increase the clearance of several agents, including barbiturate, salicylate, carbamazepine, theophylline, as we call it intestinal dialysis. That's why multi-dose activated charcoal is not considered as a decontamination method. It's actually an enhanced elimination method, because those drugs that they have the anterior hepatic circulation, they will have ongoing absorption and reabsorption through the GI tract. The drug will be metabolized in the liver. Part of it will be sent to the systemic circulation, and part of it will be re-excreted in the GI tract via the bile. So if you have the activated charcoal continuously circulating in your GI tract, it will prevent further absorption of the drugs. However, we have some complications with repeated activated charcoal administration, such as vomiting, aspiration, intestinal obstruction, and there is no clear evidence of the outcomes. So again, when you want to consider these modalities, you need to consider the outcome and is it really indicated, and what possible complications that can occur, especially in pediatrics. So they said that theophylline, phenobarb, carbamazepine, dapsone, quinine, those are most of them, you can use multi-dose activated charcoal for them. Also, they said that duloxetine, valproxen, and digoxin, and clonidine can have anterior hepatic circulations. Hemodialysis, if we want to think about hemodialysis, we need to look at the drug's properties. So a drug to be dialyzable, it should have a low molecular weight, low volume of distribution, and low protein binding. And some examples of the drugs that can be treated with hemodialysis, you have salicylate, toxic alcohols, lithium, theophylline, valproic acid, barbiturate, methotrexate. And you need sometimes to use dialysis not to remove the drug itself, but to reverse the metabolic and electrolyte derangement, like in metformin-induced lactic acidosis. For the antidote, again, many times the parents will come to us and they'll tell you, you should give the antidote. So they'll come with two requests usually. Wash the stomach, give the antidote. But do we need to give antidote all the time? Or do we have an antidote available for each poison? This is what we need to know. So in antidote usage, usually it's the same as adult indication, okay? But can be challenging in pediatric in some antidotes. So indications are most of the time it's like adults, but with a limited experience in pediatric poisoning. Most of the time these indications are off-label because we don't see common fatal or lethal drug exposure poisoning in kids. And as we said, because most of their ingestions are related to household products rather than actual drugs. So there is the indication of antidote is a little bit challenging, but we still follow the same as adults. Some antidotes, such as calcium salts, if they decide to give ethanol infusion in toxic alcohols, they will require a larger bore IV access. And this is usually difficult in sick kids with circulatory collapse. And for example, if you're talking about the atropine products and auto-injectors, we don't have a pediatric dosing atropine products auto-injectors. So sometimes we'll go with the adult dose, or we have to give separate injections for each of them rather than the auto-injector that we use it for adults. And then we need to discuss some dangerous antidote errors that we see in pediatrics. One of them is N-acetylcysteine hyponatremia. So when you give the acetylcysteine, usually it goes in large volumes. So we need to be careful. The using of adult NAC dilution in children can cause hypotonic fluid load and hyponatremia and seizure. So we need sometimes to adjust the fluid concentration or fluid dilution of NAC in pediatrics. And you go with the weight-based approach with 5% dextrose. The nitrite-induced methemoglobinemia. So pediatric, they have a different metabolism and they have a different, their methemoglobin reductase enzyme is not well maturated. So when they have a more fetal hemoglobin than adults, and they have decreased methemoglobin reductase activity, which will worsen their methemoglobinemia with cyanide antidote kit when you use the nitrites. So it's better to use hydroxycobalamin. You know that when we treat cyanide, we need to induce methemoglobinemia using the nitrites. But in pediatric, they will have severe methemoglobinemia. So in pediatric, it's better to use hydroxycobalamin rather than the nitrites in treating their cyanide poisoning. Calcium gluconate extravasation. If you have to give calcium gluconate in kids, you need to have a really large bore, or sometimes you need to consider a central line because they will have severe tissue necrosis, and it's contraindicated to use IV calcium in a peripheral line in pediatrics. Atropine underdosing and opioid in organophosphate. We are scared to over-atropinize the kids, and this will lead to inadequate doses. We need to titrate it to secretion drying, the same as adults. Do not look for the heart rate, do not look for the pupils. And children might require high doses. Insulin illoglycemia therapy in such cases, like in calcium channel blocker or beta blocker, you need to monitor their glucose closely and more frequent than adults. Remember that we said that they have poor or less glycemic glycogen reserve, so they are more prone to hypoglycemia. So imagine you are giving them insulin in high doses. So you need to monitor their glucose every 20 to 30 minutes. They are more prone to hypoglycemia, and dextrose infusion should match their insulin rate. Okay. these are some of the major antidotes that are used in kids, and you can see that ethanol usually can be used, but again, we have to be more cautious in using these antidotes in kids rather than how in adults. Okay, so some pearls that we need to know. Clonidine usually mimic opioid toxidromes, so they'll have meiosis, bradycardia, CNS depression, and you can give empirical naloxone in such cases to monitor their response. Lomotil, as we said, they can have delayed onsets in pediatrics, 6 to 12 hours, so they need to be observed, all of them. They should be observed for at least 6 hours, regardless of their initial symptoms. Typical anesthetic toxicity like benzocaine, lidocaine, that can cause methemoglobinemia in infants, and you need to give methylene blue, 1 to 2 milligram per kg as an antidote. And button batteries ingestion is a toxicological emergency in pediatrics, and you need to obtain early imaging and early gastro consultation for those children. Camphor is highly toxic even in a very small doses. 1 gram is potentially lethal, and they have refractory seizures and rapid seizures. And you need to early manage the seizure and to protect their airways earlier. In iron toxicity, you need to have to do an X-ray, because in 33 to 50% of the cases, you will see the tablets in in the X-rays. But having a negative X-ray does not rule out significant ingestions. But the presence of the tablets can warrant you to go for whole bowel irrigation as your method of decontamination, because you know that activated charcoal does not work with iron. Salicylate toxicity. Children, they will develop metabolic acidosis faster than adults, and it will be more severe. And those patients are candidates for aerial dialysis compared to adults. Hydrofluoric acid, especially it's in cleaning products and rust removal, they will have hypocalcemia and hypomagnesemia due to the presence of systemic fluoride. And you need to give them calcium gluconate and in an IV replacement urgently. But remember, you need to establish a central line for those patients. Over-the-counter cough syrups that contain dextromethorphan. It's in over-the-counter in some countries, but here it's a control. You need a prescription for these cough syrups. High doses can cause dissociative symptoms. They can have serotonin-like features. They can have seizure and serotonin-like toxidrome. So you might consider benzodiazepines and supportive care for them. Unlike adults, adults usually not present with such symptoms. Tramal in pediatric children are more prone to seizure due to tramal, because they have ultra-rapid cytochrome metabolism compared to adults. So they will present with early seizures. And this is usually apparently in some practices in the States, they give tramal commonly after tonsillectomy procedure, which is a common procedure in pediatric age. Buprenorphine sublingual strips, a single 8 milligram strip can cause fatal respiratory depression in a toddler. Naloxone infusion can be indicated, not only a bolus. Ethylene glycol in the UAE, usually it's available in antifreeze products or in windshield cleaners, and fomepizole is preferred antidote compared to ethanol. And of course, NAC is not indicated, and dialysis for severe acidosis is an indication. Okay, so if you want to look like in a quick reference, so opioid, it's the same toxidrome in adults. You need to remember that clonidine, because it's an old antihypertensive medications, and you might find elderly still use it. Antidote is naloxone. Cholinergic, it's the same as adults. You need to give them atropine and pyridoxine. Do not be worried about high doses of atropine on these kids. Anticholinergic toxidrome, they will be tachycardic, they will have mydriasis, they will be dry, flushed with retention, like antihistamines, TCAs, gymsimoid, atropine. And physostigmine is indicated in selected cases after consulting with a toxicologist, especially if they have a CNS manifestations, and benzodiazepines, of course. Then sympathomimetic, it's similar to anticholinergic, but they will be more hypertensive, they will be sweaty. You will give benzodiazepines and supportive treatment. Serotonin syndrome, the hallmark is the presence of clonus, and the exposure of a serotonergic agent like SSRI, MAO, even linezolid as an antibiotic can cause serotonin syndrome in an overdose. And the treatment is usually cyproheptadine, cooling, and benzodiazepines. Methemoglobin producers like cyanide. On those kids, you need to give cyanide who are unresponsive to oxygen, benzocaine, dapsone, nitrites. But remember that in pediatric, as an antidote, we will not use nitrites. And for methemoglobin producers, you will give methylene blue. Clonidine, remember, it mimics opioid toxidromes, so always consider naloxone as a trial. In pediatric, again, in the cardiac arrest, just we need to emphasize that you need to emphasize and follow your AHA pulse guidelines. Early specific antidote should be considered in those cases. High-dose insulin euglycemia therapy should be considered. Lipid emulsion is controversial. It's your rescue therapy. When you ran out of all your options, you can consider it only if you have a case of cardiac arrest. ECMO, which should be considered early, especially in toxicological arrest. It's your bridging procedure to buy time until you have treatment or to reverse the cause. And especially in pediatric toxicological cardiac arrest, prolonged CPR is justified, even with an unknown downtime for those patients. Drug-induced arrest is usually reversible, so continue resuscitation for more than 30 minutes if you suspect toxicological exposures, and do not end early. Try to use all your antidotes available or possible, then you can say that you tried everything. And remember that your ECMO is a bridge to recovery in most of the cases. Okay, now back to our cases. So that child, if you remember, they were hypoglycemic. They used their grandma's medications. So it was a sulfonylurea. Those kids, they have severe hypoglycemia. Usually, that child had a 35 milligram per deciliter. The hallmark of sulfonylurea that it can cause rebound hypoglycemia, and it's a long-acting agent. So those patients, they need to be observed for at least 24 hours in the hospital. You will give them dextrose infusion and a bolus, and then you need to encourage the child to eat. And they need to have a long, they said complex carbohydrates. Okay, they need admission in the PQ, and there is no indication of activated charcoal, especially because this child was drowsy. Okay, and you need to contact your poison control. For the second teen, the acetaminophen level at 4 hours was 180 mic per ml. So when you put it to the nomogram, it's above the treatment line. So you will consider giving N-acetylcysteine for them. You know your workup usually is your acetaminophen level, your transaminase levels, coagulation, and of course she's a 15-year-old teen, so you need to do pregnancy test for her. The infusion, usually the NAC is most effective if it starts within 8 hours. So if you know that you will get your paracetamol level be in less than 8 hours post-ingestion, you can wait for your NAC infusion. If you know that there will be delays in the levels and you'll get the levels after 8 hours of ingestion, start the NAC, and then after plotting the levels, you can decide to continue or stop. In this child, there was no indication for naloxone because the patient was fully awake, no respiratory depression, no signs of desaturation, not bradypneic, not bradycardic. Activated charcoal was not given because the patient came 4 hours post-ingestion and there was no suspicion of delayed gastric emptying or ileus. And of course, they will need a psychiatric transfer, but should be done after the NAC has been completed and we are sure that the patient is outside the toxicity. The third case was the child who had a topical oil of wintergreen application. So we need to make sure if it's not ingested, it's only topically applied. We need to know how many times how frequent it was applied, what is the amount of application and on what surface area it was applied. There is low threshold to treat oral salicylate. If it's ingested, you have a low threshold to treat them as a salicylate poisoning. And if you have an ingestion, you will send salicylate level and you do full labs. If there is no oral ingestion, you need to observe them for 6 hours, then they can be discharged. There is no significant clear case reports about after single topical application of oil of wintergreen. There was a case of an athlete who had a severe salicylate toxicity, and unfortunately she died after she applied the oil of wintergreen after a marathon. But this girl, she applied a huge amount in full body. She literally covered herself with oil of wintergreen after running a marathon, and then she presented with salicylate poisoning, and unfortunately she did not make it. But if a single application, usually it's benign, and you can only observe for 6 hours. One teaspoon of methyl salicylate or oil of wintergreen, it can equal of 7 adult aspirin tablets, and the toxic dose is as low as 0.2 milli per kg. Your signs usually is tinnitus, hyperpnea, tachypnea, metabolic acidosis, respiratory alkalosis, hyperthermia, altered mental status, high anion gap metabolic acidosis, and of course, if there is toxic evidence, you need to treat them with urine alkalization and hemodialysis if severe. So what's our takeaway messages? Okay. Stabilize first. Always follow your pulse guidelines immediately for any suspected ingestion. Do your ABCs. Have the risk assessment in the back of your mind. Use your toxidromes. Toxidromes usually help you to suspect the agent that it's caused and plan your treatment, because most of the time we don't know exactly what they took. Bedside tests like a glucose, ECG, they are really essential in managing those patients and treat the reversible causes or identify the caustic agents. Urine toxic screen it will not detect the synthetic cannabis, it will not detect the new drugs, they will have a lot of cross-reactivity with other drugs, so they have a limited clinical value, honestly, in treating those patients. We depend on clinical presentation, history, and physical examination. Always remember to call your poison center. Okay, in UAE, the poison center number is 800-424. They are 24 hours available. You can call them in any doubt. They can guide you and help you in the treatment. So in conclusion, kids likely most time like to explore and put anything in their mouths. Systemic approach is the key. You take into consideration the anatomical and physiological differences in pediatric population. Risk assessment is always crucial, and always utilize your resources, toxicologists, and local poison centers. Thank you.
Thank you so much, Dr. Lara, for this outstanding and incredibly insightful presentation. Thank you. While we wait for any questions from the audience, so I'd like to highlight some take-home messages for the audience. So unlike adults, infants and young children have they are not like small adults, so we need usually we need mainly to think about the differences that so they are unique. They are not just small adults. Their unique baseline physiology completely alters the pharmacokinetics and toxicodromes of the exposure we see, which is why pediatric patients can decompensate so rapidly. That's why we should think about like first, we often see a false sense of security in triage because a child appears playful even after ingesting something like one pill can kill, like such as sulfonylurea or clonidine. So the pitfall here is missing that window for proactive intervention. Other thing, second, is that we also have to move away from outdated practices like forcing milk or water for household ingestions can actually increase aspiration risk, especially with hydrocarbons. The third thing is, when in doubt, conservative and extended observation, especially for sustained release formulations or lipophilic drugs, remains one of our most powerful tools in preventing a premature and safe discharge. We are still waiting for any questions you have. I can see here question regarding any guideline on gastric lavage in children. Actually, Dr. Lara emphasizes this point. For many decades now, the gastric lavage is contraindicated. It poses more harm than benefit for these children. And also, you saw the image that's showing the tube compared to the agglomerate of the quetiapine. So it's something increase in harm more than given benefit. Dr. Lara, feel free if you want to add regarding this point.
As you said, Dr. Samia, it's it's usually gastric lavage is very distressing for the child. It's and it's usually complicating, and you see even if you use the largest oral gastric tube, still many pills, they will not be able to be aspirated. So we are just delaying a definitive treatment by doing this procedure. So gastric lavage is almost outdated. If you are in a rural area where it's really far for you to or take the patient time to go to a hospital, you might consider. But if you have a proper hospital setting where you have your proper emergency, gastric lavage is almost outdated, and it's way in the bottom of the decontamination methods.
Yeah, thanks so much, Dr. Lara, for your insights. Actually, since we have reached the end of our time, unfortunately, we need to wrap up the session. This is all the time we have for today. So I want to extend a massive thank you to Dr. Lara for sharing your time, expertise, and clinical pearls with us today. And thank you all. Thank you all of you, our audience, for this. For attendance. I can see here, I think, questions. Let's answer this question before we quit. So we can see excellent questions from Dr. Jayan. For how much time should we keep asymptomatic children under observation? This is a really great question that we are facing with all physicians are asking this great question. This is actually it depending on many factors. You have the factor of which substance was there, about formulation, if it's extended or not, about the half-life mainly. The half-life is short, you will observe for a short time. If it's long, you need to extend, you need to admit patient eventually. And we have another, the point of toxic threshold. If it's less than toxic threshold, you can advise for a home observation. And so this is dependent on many factors. Dr. Lara, if you want to add to this question, we have also another question we can.
The same, usually the standard most of the time is like 6 hours, but as we said that in some agents that we will expect delayed symptoms or delayed presentation, like for example, the antidiarrheal like Lomotil, those patients you need to observe them for more than 6 hours. But usually we go with 6 hours if it's a normal preparation, not sustained release preparations. With a clear time, we will go with the 6 hours. If we think of drugs that will cause a delayed presentation, or if the drug is a extended release, like most of the drugs nowadays, then they will need more than 6 hours, maybe go to up to 12 or 24 hours. But in asymptomatic patients, 6 hours usually would be enough.
Oh, yes, thank you so much, Dr. Lara. We have another question regarding the honey. So, yeah, let me just open. So we have if honey reduces tissue injury, should it become universal pre-hospital protocol?
Honey,
Yes, honey. I think here
as
if you if we mention maybe the button battery, this is something that we can use. It's not
uh,
something in my opinion, in my يعني,
I
opinion,
just learned recently that
yeah, it's excellent.
in button battery ingestions,
Yeah,
let eat honey.
yeah. Yeah, it's excellent remedy for that. It help a lot, يعني, but it's not something universal for all exposures, I believe.
Yeah, and like again, let's think about it. Like, yani,
Yeah,
we cannot give such an advice. Yani,
sometimes, yeah,
like let's say a generic advice that everyone will do this because
okay.
there will be some errors or mistake. Let's assume that the child have an obstruction or the bottom battery causing more severe symptoms and they are vomiting, and then you are shoving a thick honey in their throat, they might aspirate. But again, sometimes I've been recently hearing lectures or a podcast about a rural emergency. Yes, maybe if you are in a rural area, it will take time for the child to go, or maybe the hospital that you have does not have a gastroenterologist and you need to send them to other hospital. Maybe you can consider these remedies. But however, if you have an access to a proper um, management or a proper ED, it's not يعني you don't need to give it for all patients. And I remember, yeah, this is the honey thing. I just heard it recently from one of our pediatricians.
Yeah, it's actually helping even the pH, helping like changing the like buffering the pH and reducing like the caustic injury until the patient يعني can reach the endoscopy
Mm.
team. Another question here regarding the Orbeez. So yeah, the Orbeez. Um, so Dr.
Oh,
here mentioned that she hoped that you talked about Orbeez, one of the dangerous cause of poisoning.
the Orbeez, the one, they mean the small balls that they swallow and they inflate in water.
Dr. Taysir, you mean?
صح? Are these are the ones they are talking about? Because I cannot see the question for Orbeez.
Yeah. Because if it's these products, they will not show up in the yeah. Yes, she said yes, yeah. So this is will not
Just
show
don't
up
let
on the
the kids see
standard
TikTok.
X-ray.
Just, yeah,
Yeah.
just don't let the kids uh, use TikTok for the challenges, because this Orbi challenge, it's a challenge that came on TikTok, like the same way as the Tide Pods. Um, please don't even have them at home. They are very small, they are colorful, they are easy to
Yeah.
ingest, but they will have a high risk of perforation, bowel obstruction. And I believe that recently there is someone who did such a challenge, and I think that's why all teens are following that challenge.
Yeah, the issue with that is the bowel obstruction. This is the main risk. However, sometimes we have like different exposures because there is difference. Sometimes if you have it like fully expanded in their maximum, and if this maximum, I mean, size is not something causing, obstruction itself, so we don't worry much. However, if it's still not expanded and will expand inside the body, or a digestive tube, this is the harm, I mean, source of harm. So we need to check this point. If it's fully expanded, it would not cause problems. Um, uh, Regarding the other question we find here, so should imaging always precede removal of bottom battery, or is clinical certainty plus time sensitivity enough to bypass imaging delays?
Imaging should be done because the decision to how urgent you need to scope the bottom batteries depending on the location of it. So you have to do an imaging to know the location to decide you need to remove it now or can be removed later.
Yes, it's actually something like very So in case of suspected esophageal, bottom battery, so time is issue here, because if your history is highly suggestive, such as, for example, they witnessed the ingestion of, or the child, for example, presenting with sudden onset of choking, drooling, so the urgency of endoscopy removal takes precedence. So that we should never delay the transfer to endoscopy for imaging if it risks further tissue damage. So the clinical certainty here of high risk history must override the need for, confirmation. However, the location is also a key. Like we need to find where is it exactly. So I believe we finished all the questions. So with this critical clinical pearl, we have reached the end of um, and thank you again, Dr. Lara, for your time and expertise, and thank you to our audience for your engagement. Please fill the survey. We will have it pop in there or after the session, a Zoom survey for this session. We need your feedback, and we invite you for our next session, inshallah, next month, with another insightful, inshallah, topic. See you all there, and have a great, stay safe and have a wonderful day. Thank you so much.
Thank you. Thank you so much.